All right, class, we're going to talk briefly about just a few renal pathologies. Just a few. You'll get more in your clinical program, so this is just a brief look at some. All right, we'll start first with renal system infections. If someone says they have a pyelonephritis, that's a kidney infection. If someone says they have a cystitis, that's a bladder infection. A urethritis is a urethral infection. Now, technically on a pyelonephritis, the nephritis part is the kidney and the pyelo is the renal pelvis. The renal pelvis. Remember what the kidney dumps into. But I've never really seen a nephritis by itself when it comes to infection. Now, there are other conditions too. Nephrotic syndrome, nephritic syndrome. There's a whole plethora of them, but this is not for this particular course. This is just to kind of give you an overview. The course is mainly physiology. All right. Here are a few renal cancers: renal cell carcinoma, urethral carcinoma, squamous cell carcinoma, bladder adenocarcinoma, and then you have some other types. So again, I'm just showing you the various cancers, some of them that you have in the kidney. These are cancers. Okay. What's up next? Kidney stones. Kidney stones may form when the normal balance of water, salts, minerals, and other substances found in the urine changes. How this balance changes determines the type of kidney stone you have. Most kidney stones are calcium type. They form when calcium levels in your urine change. So in other words, too high of solute and not enough solvent. So here's a picture kind of some of the different kidney stones. Now those things are real painful. I'm fortunate I've never had it, but it starts up in the kidney and it travels down. And when it's traveling down those ureters, the pain is excruciating. There are different treatments for it. Sometimes you have to go up and pull them out. You can go through the urethra. Sometimes you can do lithotripsy. Lithotripsy is where you use kind of a high frequency sound to do it. So there are various treatments depending on what the size of the stone is and basically what the type is, shall we say. All right, let's look at a couple more, then close here. Now here's what we call stress urinary incontinence. This occurs in females. You'll hear on TV where a woman will cough or sneeze and lose urine. This is what I primarily did a lot of work on in gynecology. And basically what it involves is a weakening of the pelvic floor where this urethrovesical angle. I want you to notice something real quick. This is the bladder and this is the urethra. That angle is important to maintain the sphincter, to maintain that urethral sphincter that keeps continence. And when a woman has a loose pelvic floor, for either from aging or too many kids or whatever, you lose that. And that's where we have to go in. We have various surgeries that we can go in and do to be able to try to repair that, where the female does not have to be embarrassed when coughing and sneezing and losing urine. Okay. When we're doing that particular procedure, before we do it, we want to check out and see what's the condition of the bladder. Is it the loss of the urethrovesical angle, or is the bladder itself having trouble like spasms? So over here, I introduced what we call a cystometrogram. A cystometrogram is when we put a catheter up in the bladder, and then we take another tube and start putting water into the bladder. And then one of them is a measuring tube catheter. And we're looking at the pressure in the bladder as we do that. So we're trying to check out that pressure to see if there's bladder spasm, or is the bladder atonic, which means it's very weak. Okay. So these are what we're looking at. There's that detrusor pressure in the bladder. So these are evaluative tests to do it. The other test we do is something called cystoscopy. Cystoscopy is where we take this flexible deal. Of course, the person will be under anesthesia, and we pass it up through the urethra up and look into the bladder and everything to see if we see irritation or other things that may be causing. And not just for stress urinary incontinence, for other conditions too. Looking for tumors, looking for excoriation, which is scarring, and various things of that. So that's called cystoscopy. Looking inside the bladder, going up the urethra, and then this is what we call the cystometrogram. Okay. Now, here I mentioned what the peril of the female, one of the most common perils of the female, stress urinary incontinence. For the male, one of the major perils is something called benign prostatic hyperplasia, BPH. It's a benign condition. And what it basically is the prostate gland enlarges. Now, you see, for the male, remember we had a prostatic urethra. If the prostate got too big, it would compress. Now, what that would do is that after the person would void, there would still be a lot of urine left. Let me say it again. After the person would void, there'd still be a lot of urine left, so it wouldn't be too long before they'd go back to the bathroom again. This is a male. So they would have what we call polyuria, or to say it more in a more layman's term, frequency of urination. Now, I said after the person voids, there will still be urine there. So then we come to this drawing here, what we call the post-void residual. The post-void residual. Okay. What the post-void residual basically is this. This is how we would determine it. In both man or woman, we would say in the office, go and urinate. Urinate everything out you have. Then what we would do is come and take a catheter, okay, and stick it into the bladder, go through the urethra, and then evaluate how much urine is still left in the bladder after you urinated. Okay. So what you should see is less than 50 cc's. You should see on a post-void less than 50. If it's greater to let's say 150 cc's, okay, then it might be due to many different things. It could be the benign prostatic hyperplasia, or it could be but in this case, you don't want to use bladder relaxing drugs, so they make it worse. Now, if it's greater than 200, then we're definitely looking at outlet obstruction, which could be this here, or it could be something in the female that's obstructing this right here. Now, for example, which is a normal thing to obstruct it, sometimes females, while they're pregnant, the baby's head will press down, and so it can do that. So there are many reasons for this. But that's what we call the post-void residual. Post-void residual. So anyway, I have not named nearly all the conditions present in the field of renal medicine or urology, but I wanted to introduce just a few, some of the more common conditions that we see, like infections, females losing urine on coughing and sneezing and things of this nature. All right. Thank you very much.